Perfect. Well, thanks everyone for joining. We've got Kristi here, which is great. It's the final part, as it were, of this current series. The Ask Kristi. Kristi's going to kick off with a couple of protocols. But I thought what we do is, because given the number of questions we had on the gut barrier panel, is that we just go through some of those to start with, and then we'll kind of hand over to Kristi to go through not only the protocols but the case studies she's got, a couple of them there, and then we'll go into the questions. We've got about 20, so feel free to add to that, and then we'll kind of crank through that if that makes sense for everyone. Again, just to kind of highlight the offer that we've made. So again, if anyone wants to try the test, just kind of mention Kristi, email KBMO at the KBMOdiagnostics.com. We'll be happy to kind of offer that $200 discount. So discounted kit discounted down from the $385. Again, you're all familiar already with the allergy versus sensitivity versus intolerance. And the key difference with the KBMO test is we're looking at the whole immune system versus half of it. So the idea is, rather than just looking at exposure, we're also looking at the innate immune system, which again was one of the key differences in terms of when you think of KBMO versus some of the other tests out there on the market. As I mentioned, we had an overwhelming number of questions around the gut barrier panel. So we thought we'd kind of kick off with a couple of slides on that, and then kind of hand over to Kristi to kind of take some of the great questions that we've got as well. So Kristi kind of fits in on this. As you're aware, we've launched this gut barrier panel, and really kind of it was in response to when we started selling the test, we were going to hearing from people. We really love the food sensitivity test. We love the multiple pathways. We love it's patented. We love it's eliminating those false positives. But some providers were saying, look, we don't test using food sensitivities because of, we think the patient has leaky gut. So that kind of stuck in our minds in terms of thinking, why are they thinking and all kind of guessing, why aren't they testing? So that was the kind of genesis of how we came up with this gut barrier panel. As you're all probably familiar with now, the Candida, the zonulin, and the occludin. So the Candida looking at early stage dysbiosis, the zonulin looking at those tight junctions and how well they're functioning, and the occludin looking at those tight junctions in terms of structure, in terms of how robust they are as well. And we're looking at these two pathways. So the IgA, obviously a secretory marker, so indicating localized in the gut and generally early stage. And then the IgG and the complement, generally more systemic from a system standpoint, as well as in terms of how long it's been going on for. This happened to be one of Kristi's patients, but I won't call her out until she can remember which one it was, given the number of these she's run. But again, the interesting thing for us was it was a patient who, again, Kristi's doing a lot of work in mold these days. So it's linked with mold, as well as some issues linked with depression as well. So again, that whole brain gut, and again, there's some good questions there, which Kristi will go through as we go through that presentation as well. So again, just a brief note on the zonulin. That was a unique test to KBMO. We came out with that. It took 4 years of work with the likes of Dr. Pisano, as well as our very own Dr. Brent Dorval, working on that. And we solved some of the key issues that I don't think some of the other tests on the market have even observed yet, which is low positivity rate. It was cross-reacting with haptoglobin and properdin. The protein assay was pretty unstable in terms of different results from morning and afternoon. And again, one of the big questions that we always get asked is, should it be a blood or a stool test? And so we worked with Dr. Pisano on that, and he kind of said to us, look, yes, we need to solve all 4 of those issues. And so that's when we came up with this recombinant zonulin protein, which addresses those big concerns of low positivity rate in terms of we're seeing pretty much very similar data to what he saw and had published in the Lancet back in the early 2000s with his cohort of celiac patients. The stool versus blood, he said to me, look, the only research we've done is in blood. So again, that gave us an easy answer in terms of making sure that it's a blood test, which then fits very nicely with the food sensitivity testing that we're already doing. And then again, by developing our own recombinant zonulin protein and going back to basics, that enabled us to make sure it wasn't cross-reacting with the haptoglobin and properdin, which the other protein assays on the market do. So again, just to highlight the importance of science and the ability we have internally to deal with those scientific issues, that was a zonulin test that we started on its own and then added those other markers as well. And Kristi will go into these in more detail. But again, that's now found on all the reports on page 3 with a brief description of each one of the markers so that they've got an understanding for the patient of what it is. And there'll be links now as well to the occludin on here as well. So we've added that to it. And then the gut barrier interpretation. And again, there's some great questions that Kristi will go through, talking about some of the protocols that she's had most success with and some of those supplement companies. And last but not least, before I hand over to her, we've also added LPS, which was maybe just there before we went into the third version. So again, LPS, a key marker of gut barrier function, thinking about it as a continuum. So looking at it in terms of a key marker linked to gram-negative bacteria. As we kind of touched on the innate immune system, which is where the complement kicks in. Again, LPS is a big marker in that area, as well as some of the damage to the gut and the kind of blood-brain barrier. So again, it's a systemic marker, as we talked about with the IgG and the complement. And so again, we wanted to add that in there. And again, that blood-brain barrier is alive and well. And I know Kristi's going to talk into that with some of the questions people have got. And again, gut permeability, as we all know, is linked with increased endotoxin absorption. Hence why we wanted to make sure LPS was in there. And that was really one of the key feedbacks we had on that panel, and so people are really enjoying it in terms of giving them an extra angle, but more importantly, with the LPS on there, that's been another important element. So at that point, let me hand back to Kristi. Let me see if we can share screens, and then we'll allow Terry in there. So I think, Kristi, you should better go in and just do it, but let's try just to make sure.
Perfect. Why don't we also too, there's so many good questions. I've got that up on my screen here too. So let me kind of segue us into the cases too, with just kind of taking on a couple of the questions here. So one of the things I appreciate that you kicked us off with talking about is looking at the LPSs and, you know, what are some of the conditions or what are some of the things that we think about, right, when we get a report coming back in that direction. So for me, the main thing I'm thinking about obviously immediately is dysbiosis. I'm going to plant SIBO in my mind. You know, I'm going to do a much deeper exploration on all relevant gut challenges, right? So I'm going to take a much more detailed GI detailed history and have a more in-depth symptom conversation with them. The symptoms, you know, that I see a lot of my patients presenting with when they have those types of bacteria secreting endotoxins in their gut, honestly, the main things I see is fatigue. Right, so it's contributing to overall energy, mitochondria, coming in kind of from that perspective of ATP production and mitochondrial efficiency. So I'm going to see physical fatigue and mental fatigue, which is pretty much almost across the board, right? I'm going to say probably 80 to 90% of people will express those symptoms. Second, skin. You know, I see so many patterns manifesting at the surface of the skin, right? Because of that interesting connection between inflammation and some of the endotoxin challenges inside of the gut. I see that expressing outwardly quite commonly. So different types of rashes, where those skin reactions may be taking place, and of course, exploring whether there's a diagnosis of eczematous patterns or there's a psoriatic pattern that may be there. And again, often that may overlay with different types of candida or candidiasis type skin problems. So I want to certainly ask a little bit more creases, sweat areas, you know, if there's anything else that they're noticing in skin. And then say the last that is just very, very common for me to see in my patient base is joint pain. So many of them ache, they're sore, they're stiff, their joints hurt. So I always put arthritis on this list. When I have patients who happen to be presenting or jumping into my practice and they come in leading with joint pain, I'm now going to take a very detailed COVID history because of how much we see the COVID triggering of inflammation being engaged. But I'm going to dig deeper and deeper, and I'm going to use the full KBMO panel and this gut barrier profile as an ideal guide for me to get a sense of, well, how much does the diet and how much is the gut engaged in invoking and producing inflammation with these patients? So if I were going to, my takeaway, gut, skin, joints, right? If like, what are the top, you know, conditions that I tend to see presenting, right? So then looking at food, real foods, you know, what are some of the things that you need to look at to try to get the LPS back in balance? Honestly, it's not just eating real foods, it's also reestablishing that microbiome. So when you're thinking about real foods or suggestions, you're going to need to lean in a direction of some of the stronger antimicrobial foods. And quite frankly, I'm not convinced that diet alone is enough to correct an LPS imbalance. I don't think clinically comfortable just relying on, say, garlic and onions, or, just certain additives that I would be putting into foods. I really want to utilize extracts for that. I want to make sure that we're targeting and tackling imbalances in the gut. And I may go on, following my KBMO report with my gut barrier panel, and I may go on and actually run a stool sample. It's not uncommon. I come out of this screening and decide, no, I do want to know more. I want to know what's growing in there. I want to look at that tube. I want to see where there's testing capabilities to identify more present in that microbiome. So for me, and it might just be because I'm an old dog in my old trick, but I've been using what was Great Smokies, which became Genova, for honestly 26 years. So my go-to, the company and the test I find reliable and I'm used to reading and predictably treating against is the GIFX that Genova has put into play. So that will often be my follow through test, because that can help us understand which particular bacteria may be present. And again, culture things out in the lab, get us a little better understanding of what could have grown in that Petri dish. So foods, stepping back, you've got to be mindful of if they're SIBO-derived bacterial patterns, you're going to have to be careful and mindful of fiber, right? When it comes to fiber and prebiotics, in certain gut milieu, you need a little bit of fiber, but if you start pumping too much prebiotic in there, you end up with gas and bloat, right? So it's this kind of very gentle teeter-totter that we have to be very mindful of and step into very kind of low and slow. So when we come back around and talk about formulas, protocols, and such, I would tell you again a little bit more about my use of the GI integrity formula, the role that I bring in different types of pro and prebiotics, including spore probiotics. I think there's a very important role here for spore probiotics when we are looking at the LPS presentation and the candidal markers starting to come back and flag. And then there's some strong antimicrobials that I've got to keep in my toolbox because I'm going to draw on them and I'm going to utilize those. So I'll go over some of those natural antibiotics and anti-candidals as well. So foods, kind of, James, I guess I would love to know, how do you all reply to this great question, which is, well, what happens if foods show up on my report and I don't eat them? They're not a part of my standard diet, right? I see that all the time. I've seen that for 20 years, that, these screens will pick up that connection with the blood response. Go ahead and dive in, and you go first.
Yeah. So again, what we do for all the providers is we provide a really detailed provider's guide, and in the back of that, we've got a cross-reactivity chart. So that shows you some of the foods that they may cross-react with. Generally, the advice we give to most kind of patients or providers rather than patients is to say, look, if they're not eating that food, certainly look at that cross-reactivity chart to see if there's any foods in there that go, those are the ones that must be triggering it. So that's generally what we try and do there. I wouldn't generally recommend going straight into the cross-reactivity for every food, on the basis the idea is it then becomes overwhelming for the patient and you're kind of almost like, back to square one, as it were. So the idea is, if they're not eating it, then look at the cross-reactivity for those foods and those foods only, versus kind of overwhelming them with suddenly going from a nice list of 5 to 10 to 30 or 40 foods, which is not very helpful. And all you're going to do is cause some level of food anxiety, which is, I think, one of the good things that we've avoided with this test.
Yeah, I appreciate that answer a lot. So ditto, right, across the board. And so what I would say too is, I'm also loving that gut barrier panel as an opportunity to be able to say the leaky gut does or does not have something to do with this, right? Because if I do not see an elevated zonulin or occludin levels coming back positive, I'm honestly going to be stricter with the patient. I'm going to be less forgiving, because I don't think we can treat our way through the leaky gut to be able to get underneath the inflammatory invoked foods, right? And actually, one of our first cases is a really good example of that, where, I agree with, there was one of the questions in here that said, Okay, so I don't, or you opened with the comment, I don't order any of these types of tests because I'm assuming all my patients have leaky gut and I can't trust the results, right? Well, that's 100% why I've landed in the KBMO test bucket after honestly 20 years of dabbling with a lot of other IgG4 tests and running and really having a lot of experience with other companies and that data. Yes, that is one of the powerful things about looking at an IgG4 is we do get a sense of what is making its way through that broken down gut barrier. But that doesn't mean we don't want to eliminate those foods, right? It's part of finding the source and finding part of the cause. If you got a patient who is tipping the scales in these 2+, 3+, 4+ levels, there is of no benefit for them to keep eating those foods in either direction, whether they've got the permeability problem or they don't. There's no benefit, in any way of them continuing to eat that way. So regardless of how that gut barrier panel comes back, I am going to want to restrict the food exposure, or maybe it's the frequency with how often they're eating those foods. And again, it's not based on just the test. It's based on their whole story, right? Being able to step back and look at the functional picture and get a good sense of those connections. This first case that I'm going to pop up answers the next question, which is how often do you go back in and retest, right? And the retesting question around both the fit test, whether you're choosing the 170s or 130s, or you're just reordering that gut barrier panel. Kind of say my golden rule in general with food screening has been with adults, if I'm going to retest a full food panel, I'm not usually going to do that earlier than a 12-month window. So I would say for me, 12 to 24 months is kind of the average for the full food profile to be able to keep modifying the patient's program and continuing to make sure that the current diet is serving their best needs. Now, if something's changing, if we've got esophageal, eosinophilic esophagitis, or we're dealing with an ulcerative colitis, or we've got a patient that just picked up a new H. pylori infection, or downstream has a flare of ulcerative colitis or such, when we're kind of looking at some of those aspects, let me quick here, there we go. So when we're kind of looking at some of those aspects of the patient story and looking at pieces of their history, I might order more often if I'm seeing much more of a severe type of a picture that is playing out in the gut. I have a different answer for the gut barrier panel. Granted, that is now new in our repertoire of options in this last year. I think an absolutely wonderful timeline for following up on just that gut barrier is somewhere around 6 to 9 months. So in our flow and in our program, my new flow is getting that original test screen in the larger, more comprehensive fashion to kick things off, and then going back and rechecking that gut barrier at either the 6 or the 9 month mark, holding our ground again and going back maybe around the 18-month window for a full complete panel workup. Because it takes time to heal the gut, to go in there and repeat a gut barrier panel sooner than 6 months, to me, doesn't feel like the most cost-effective and realistic way to be able to utilize and position the benefits of this test, right? So it takes time to heal a leaky gut. It didn't happen overnight, and it absolutely takes time to reestablish that healthy gut barrier, identify other bugs and critters in there, deal with the bugs and critters in there, and I love years ago, gosh, this must be 15 years ago, possibly, when I was on a lecture circuit working with actually Metagenics Australia at that time. And one thing that I loved was they just simplified this whole gut process into breaking things down and basically saying we need to weed, seed, and feed. And I love that. We need to weed out all the bad bugs. We need to seed in all the right things that fuel and feed the entire microbiome, right? And we just need to feed it lots of good probiotics and healthy foods and wonderful resources for immune gut remodeling. So the weed, seed, and feed piece, that doesn't happen right away. It takes months to get there. So let me jump back over here. So what symptoms do you see the most with? So I think kicking it off from the very beginning, gut disturbance, patients suffering from either diarrhea or constipation. This is my 100% first go-to test. Patients who experience irregularity in their bowels or a swinging bowel from that dense firm all the way to the soft diarrhea, or the patients who are just always constipated or always struggling with a soft, wet stool. They all are going to fall under my banner of wanting to dial in the diet, identify inflammatory triggers, and get on that food plan as fast as possible. So I'd say those are by far, like, this is the first thing I'm going to do. There is no way anyone's going to leave my office presenting as a new patient with any level of gut dysfunction without this being a big part of what we do first. So those are kind of a key thing for me. Let's see here. I want to also jump down to this incredibly astute and on point question about, given now the articles that are starting to come out on long haul COVID and looking at that post acute sequelae COVID, and then looking at even some of the research coming out of Harvard recently published, what are we seeing in regards to the microbiome? Absolutely, without a doubt. When we look at the underlying causes of long haul COVID, susceptibility is breaking down to a couple big areas, right? One of them is a disturbed microbiome. A second area is altered or compromised mitochondrial performance, right? We know that is a huge underlying factor. And three, I would call it the interface of genetics and epigenetics, because we are seeing that for many patients who are developing long COVID symptoms post-infection or post-vaccine, or not even knowing that they got exposed because they didn't express a full-blown infection. So those post-spike protein exposure, for those falling in that category, we absolutely are seeing that there's some interesting genetic underpinnings to be mindful and aware of. In particular, those ACE2 receptors, right? Because those ACE2 receptors, that spike protein is going to attach to those ACE2 receptors, setting off a cascade of inflammatory waves, which in the wrong patient at the wrong time with a certain set of genetics may become an ongoing fiery storm, right? In which the inflammasome is then turned on. So the things I'm looking at in my nutrigenomic panels that would make me think gut, microbiome, foods, and long COVID syndrome, I'm going to absolutely be looking deeper in patients with glutathione SNPs, inflammatory SNPs, diabetes and obesity SNPs, right? As well as looking at those with the ACE2 receptors. So I think we are on in a very important kind of cutting edge moment of starting to get a better sense of underlying causes when we're looking at long haul. And I believe I said this last time in June, but there is a wonderful piece of momentum out there in our functional medicine community by Ovation Lab, helping to train some long haul COVID protocols for our practitioners who are in this space of doing root cause care. So Ovation Lab has a really nice training program, and we have been implementing their long haul COVID program in our practice now for 8 months with phenomenal success. And we've run about 150 of our patients through that. The original clinical trials are now coming through, and just know every one of those patients I have a KBMO on, right? Because I need to know how to help them eat and how to regulate some of the inflammatory responses, and so the data around managing long COVID and treating these underlying factors, which include vascular damage, vascular inflammation, glutathione challenges, inflammatory SNPs, and of course, healing the microbiome is really key and imperative. So I'll just pause there. If you have any other comments, James, at all, as I'm going to pull up my deck and look at a couple of our patient cases together.
Yeah, no, absolutely. Hopefully that answered Terry's question there about the length of the protocol. So hopefully that helped there. There's a quick question here from Mary just asking about the Fit 176 app and where to find that. So if you contact the office, generally the way we do that is we delay it 14 days post the test results coming to the provider. So the idea is then you've had a chance to review the results with the patient, and then the patient has the app as a reminder. So that comes to them automatically as long as they've put their email on the requisition form. But again, if you're concerned about you didn't get hold of one or anything like that, please contact the office and they'll make sure you get hold of that. So hopefully that's some of those ones there as well in terms of the app and the length of the protocols. And then here's a really good question, Kristi, which I think is probably one that everyone is thinking about, but a great one from Terry. Is there a tip for keeping people compliant when we're talking about keeping them going for 9 months? I've heard providers say 6 months, for the gut barrier panel between retests, but 9 months obviously sounds like something that you've had a lot of success with as well in terms of, the feeding and the weeding, which I hadn't heard before. So that's a great statement. So, but again, any ideas or tips of the trade on that, I think would be greatly received from everyone.
Yeah, I think right out of the gate, I'm going to ask the patient to get really familiar with their food list. And it may take them a week, it may take them 3 months, but I want them to get to a point where they feel like they've got their head and their mind and their emotions wrapped around their food results, right? Because the tough part is not necessarily leveraging the practicality of these results. It's often dealing with the emotional stress and strain that goes with either changing your own diet, getting off of foods that you love, or having to figure out how to balance your food plan when you've got a family and you've got one person with a lot of challenges and complications that doesn't necessarily impact everybody else in the house. And when one report affects a whole family, right? So those are the hardest times, right? I have to just say right out of the gate. So in the beginning, I want people to be realistic. I want them to take their time. I want them to get familiar with the list. And at some point when they're ready, and I really don't want this to be months and months in advance, I would love this to happen within the next, like 6 to 8 weeks of going over the results. I want them to start reducing. And then I want us to hit a moment where we say, we are going to give this a 21-day window. I want one clean 21-day run of being perfect. And when I say perfect with my patients, it's not something I want long-term and forever. But when I say perfect, I want them off every light green, yellow, orange, and red. I don't want them eating any of the foods that are going to show up and provoke any inflammation or be engaged in provoking symptoms that they're experiencing. And while we do that 21-day, what we'll use in our office is a medical symptom questionnaire, which is available through IFM and other resources. And we built it out into an Excel sheet. And so what we do with our patients is I have them write day 1, day 7, day 14, day 21. And I want to talk to them at the end of that 21-day run. And I want to look at the symptoms. I want to hear how they're feeling. I want to know what it was like, but I also want the patient to track that symptom chart weekly, because quite frankly, so many things go away and patients completely forget which symptoms have gone away because they then just become focused on the new symptom of what's bothering them the most now, right? So I want subjective, objective tracking, if that makes sense. So I want a 21-day run. I'm not expecting 9 months of perfect, but I am expecting 21 days of good detective work. And we're going to work on that gut remodeling program where I'll tend to have them on a gut program where they're doing a prebiotic, a healthy, ideal fiber. We're going to work on the microbiome using spore probiotics and Saccharomyces boulardii type formulations at night before bed. And then if there is a bacterial or yeast or mold problem, I'm going to give antibiotics around breakfast, lunch, and supper. And I'm going to give all my gut restoration support at night before bed, which I think I modeled that in the last couple case conversations that we talked about. So yeah, I think it's an awesome question as far as timing. I want one 21-day run of perfect. And then from there, I negotiate. Right. From there, I'm negotiating with them, based on how much improvement did they have and how complex is their case. Right. And if that's all we have to do and their symptoms are 80-90% improved, then I'm going to coach them to an avoidance plan. And I'm going to keep working on anti-inflammatories and gut support. Quite frankly, one of the things I love about this expanding report, as we're continuing to get new markers on it, it seems like year after year, I also love all the ingredients. And so I use this as a gauge with all my new patients and follow-up patients at times, because I want to make sure that we know ingredient-wise, everything from stevia and monk fruit to turmeric or rosemary extracts or chocolate, vanilla. I want to know that as we're navigating and we're making some decisions about their supplements, especially fish oil. Oh, it's been so beneficial to be able to use this as a screen. And we may find that people are reactive to salmon or halibut, or we've got to be mindful of calamari and squid derivatives, right, with our DHA. And over again, as we get cleaner hits with choosing the right fish oil for the patient, again, now our fish oil give the benefits of inflammation without the counterproductive inflammatory response that's coming with taking, which should be an anti-inflammatory, right? So what I love is not only the diet guidance, but I really appreciate the expanding list here so that we can navigate some key things with supplementation.
Kristi, I was going to pick up on that symptom checklist. That is such a great idea. And I remember kind of almost 10 years ago or 15 years ago when I started getting involved in this area, that was such a key tool, because you're right. It is amazing how many patients get amnesia on what their symptoms they were when they came in the door. So
all the time, right?
It's such a great reminder. And it's a
very
simple thing to do. So it's not
super easy. Right? It's free. And kind of after the weeklies, right? Because I go week in the beginning, right? Just because I want to really capture that 21 to 28 day. Then as we slowly start to add things back in, or we challenge and we look at how they respond to those foods, then I like to continue at least a monthly check-in on that MSQ, because if they see, oh, my number went from 112 down to 8, and then they slowly start bringing their foods back in and they wonder like, well, why am I back up to a 50? Right. I love the ability to come back and say, well, could we consider and explore with some curiosity here the potential that your foods are making you sick?
Yeah.
So I use it as a big coaching tool. Right.
Yeah, that's a great point. And I guess we've been doing it for so long, you forget about some of the real key elements, which is so critical in terms of success. So kudos for bringing that one up.
You got it. So absolutely love this case study. So this is a woman who is born in 1964, and she, interestingly, has spent the last 25 years of her professional career as a dietitian. And so she has learned a ton about nutrition. She found her way into metabolic syndrome and some key diabetes education and diabetic education over the course of these last 10 to 15 years of her career. And so for her, let me get that video off. There we go. And so for her, I hadn't seen her in years. And it was interesting for her to come back into my practice. She was ready to dive in, and she's like struggling with a lot of health challenges in this post-pandemic era, as many have, and said, look, we're kind of recalibrating and sort of starting from scratch. She said, I need to clean up my diet. I can't think, I can't focus, I'm exhausted, I'm tired. She said, and I keep picking up infection after infection after infection. Right. And so she said, look, I know how to eat. I'm doing my best to try to get my blood sugar managed. She said, but I am really struggling. And her blood sugar levels and her hemoglobin A1C was way too high in what we would be expecting based on her knowledge and her dedication to her diet. So lo and behold, kabam, we get this report back, right? And this is a woman who has worked on leaky gut, who has worked on permeability, who is very mindful, right, of that aspect of it, because it's been a part of her work. We were both pretty shocked, I have to say, when the test results came back, and we were like, oh my gosh, look at what we're dealing with here. How interesting to see that her candida came back elevated, that LPS was extremely elevated. So as we dove into and we looked at the context of her report, and dove in and looked at where was she having areas or challenges of inflammation being reported, it was kind of impressive for us both to say she has worked for like a decade on leaky gut. She worked on gluten and wheat for literally like a decade. She was clean. She modulated those foods. She cleaned them up in her diet. She did a great job. So not only do we see a nice gut barrier panel, but we also see that some of those standards that she knew bothered her in the past are no longer there. So this is the exact type of test result that's coming back, James, where I'm not going to say go 21 days. Because the leaky gut is not the cause. She's been healing the leaky gut, but she has not gotten to the microbiome infection component. And if we didn't do anything and we just sort of left that candida and the bacterial dysbiotic picture, it would only be a matter of time before that leaky gut would start showing up again. Right. So for this case, I don't want her to do a 21 day. I want her to get off this stuff. Right. I want her off these foods, and I'm advocating for her to stay off these foods for a while because we're going to dive deeper into that microbiome, and we're going to be working our way through candida. We're going to be working our way through gut microbiome cultures. I definitely did order a mold test on this patient just because there was a possibility of mold exposures. I'm looking at her labs, which I didn't put in the presentation, but she's equivocal and has the presence of 3 out of 5 molds. So there's a possibility that there's a mild light mold issue going on here, but it's more of a candida microbiome dysregulation piece, less of an environmental mold toxicology case, which is not always the situation, right? As a matter of fact, this morning we did a mold consult with the worst standing mold picture I have ever seen, and the mold doctor that I collaborate with said is the worst test result she's ever witnessed in over 10 years and 10,000 mold patients. So we had that patient this morning, and you know, he like perfected his KBMO, did an amazing job eating that particular diet, and gosh, we were getting stuck in these areas around brain and brain performance and energy and exhaustion. And so kind of turned over all these stones and finally got the clue from the KBMO that there was a little bit of yeast that was showing up and there was a little bit of candida that was showing up. So we went on and dug deep in the mold test. Oh my gosh, this is a patient whose ochratoxin level, which should be less than 2, ideally less than 1.5, came back at 36. Just outrageously elevated. So no wonder we couldn't get all the way through managing via the gut, because now we've got to get in there and do some actual effective mold binding and liver work. So hence, whenever I'm looking at these panels and I see yeast kicking up and I see candida showing up, I just want to know that my clinical thought process for these patients is also long haul, mold. Is there any Lyme, and are there any other co-infections we should just be asking about? So I'm definitely going to want to screen and follow up with mold where indicated. All right, this is another awesome case study. This gentleman, when I met him, he had an ileostomy bag. Okay, so when he presented, he had such severe ulcerative colitis that he was bagged when I met him. He is maintained through the Mayo Clinic. He'd been going there for the previous 2-year window. When he was visiting with the gastroenterologist, they told him diet has nothing to do with his ulcerative colitis, that there was nothing that they could do for him other than Stelara and Azicol, which are the 2 meds that he came in my office on. He also is highly driven, highly sympathetically dominant, high stress load, entrepreneur, business owner, runs like 100-person factory and company. Smart guy, eats great, but it was interesting when we first met each other, the debilitation that the gut obviously was creating in his life. And he loves to motorcycle ride. He loves to ski. He likes to go hunting with all of his friends. He likes to travel. He likes to, you know, get out there and do a trip a month in the perfect world in every season. He wants to snowmobile. He wants to be out there, you know, in Montana. And so this was a guy who literally came in begging and saying, look, I need to be mobile. I need to be flexible. I need to go places. I want to live my life. And his gut was holding him back severely. So when I first met him, his first reports came back showing high levels of permeability challenges. The first test I ran on him was before we had a gut barrier panel here at KBMO. Ran countless stool cultures on him over the course of the last few years, after looking at data and stool cultures run by other functional medicine docs in the previous 5 years. So we dove in deep, cleaned up his gut. You know, he came to me with a clear permeability problem and a severe gut disruption. He wasn't responding to antibiotics. He wasn't responding to care. And as I mentioned, the ileostomy bag was kind of our gauge and our goal, right? Because he wanted that bag out and he wanted to be having his own bowel movements again. So we did a massive gut remodeling program for him. This is a very recent test that just came back. And so we now had, and it was in May. I was so bummed, James. I should have waited till June or July to run this one, because then we would have tucked that LPS on. He's like, I think it's one of the last tests that I sent off in May before we had the new add-on. And so he came back with some of that candida showing up in that secretory IgA pathway. So his case program and what got us to this point of him, this is him doing better. Okay, so interesting looking at this report. This is he and I sitting down saying, look, you're not going to get to put gluten and dairy back in your routine. right? We've been working hard for the last 2 years on getting that gut permeability to seal up and heal up. He's doing great. The bag is out. He's feeling good. His symptoms have cleared. His weight has stabilized. But for he and I, this was such an important come back around full circle moment to say, you know what? You're not going to get back on the dairy and wheat. For him, the autoimmune risks are too high. The inflammatory challenges too high. We are absolutely adamantly going to be staying off of these particular foods. Those two big families are not welcome. Eggs, dairy, and wheat, we've got issues with and we've got challenges with. So he is going to go on and look at maintaining the high reactions. And in his case, we're talking the reds, orange, and yellows. He is maintaining a complete withdrawal plan from these. And treatment plan wise, he and I had such a fun visit. We talked on 8/8. So I guess that's just a week and a half ago. And he basically told me his bowel is the best it has ever been. He's been biking. He's on the motorcycle. Things are not set off. This is the best he has ever felt since we've had a chance to talk with each other. And I wanted to use this case because he's been working with me for 2.5 years. Right. And he was working with providers, and I'm not kidding, for probably a solid 7 to 8 years before he even ended up in my office. Right. And it's because all the other gut work he had been working through wasn't changing the pattern. And he was basically seeking any other options because Mayo Clinic told them, this is the way it's going to be. This is how you're going to be. You've got ulcerative colitis. The bag will be present, and this is how it's going to be for the rest of your life. So just get used to it. And he just kept saying, I'm doing all this Google search. I feel like I could change my diet. Are you sure there's not something else that could be done? And so we did a lot of microbiome remodeling in this patient's storyline, and symptom improvements are substantial. He's just got to be really careful. And we are not going to be putting the gluten, the wheat, the egg, and the dairy back into his revolving rotation. All right, this is another follow-up case. Oh my gosh, I love it when the follow-ups come back like this because it's just like, oh, it's like happy day, right? When we see these types of results coming back. So this is a young gentleman who this KBMO is a follow-up after, oh gosh, I must have known this young man for about 8 years. Yeah, I must have met him when he was about the ages of 12 or 13. He is now 21. And so he came in with his mom years ago when he was in middle school and had substantial challenges with brain, memory, focus, moods, energy. And so we started correcting gut and diet years ago on this young man. And so he currently struggles with some levels of anxiety and some mild, very mild GI distress, which we have come full circle to talk about is probably related to the beer in his now over the age of 21 diet. So we kind of been talking about, how helpful or not helpful that is in his diet. But sure enough, all of a sudden he turns 21, his friends want to drink. So there's this new introduction in his life and it's called beer, right? And look at this report. This is not a young man that can handle or tolerate beer that's going to be coming from a gluten grains, right? That's going to be coming from a wheat base. So we had the opportunity to talk and say, look, you have been treating your gut for years and all these pieces are better. All these areas you've worked so hard to correct and normalize have made substantial improvements. But that gluten and wheat and the beer, we've got to, come back around and see if we can't find some better options. So honestly, he and I are negotiating around alcohol, right? So this young man's case management at this point, his leaky gut management worked beautiful. The intestinal permeability support went well. Now we are at a place where we're trying to figure out how to deal with the social pressures of being a 21-year-old where all your friends want to go out, they want to drink beer, they want to hang out, and you know that your big source of gut and brain irritation is coming from your beer. So yeah, interesting. I'm loving these new follow-up reports, James. It just helps me so much know what do I have to keep working on with patients and when I can move on, and I can keep moving further and progressing their care.
Good example. Here's a really good question, and I'd love to get your thoughts on this. What if the gut? This is from Madeline. What if the gut barrier panel looks good, but many food sensitivities? So I've got a sense of how we'd respond internally, but I'd love to get your input on, if it's a green gut barrier panel, I'm guessing, Madeline, with all 8 markers, but many food sensitivities.
I am absolutely taking them off those foods because there's something about those foods that's triggering inflammation. And it's telling us that the source of those responses in this upregulated or highly reactive, responsive immune system is no longer, or at the moment is not, the leaky gut. So I'm going to be stepping back and thinking about I'm going to be thinking about mast cell activation syndromes. I'm going to be thinking about histamine reactions. There's a host of other things that can lead to the immune and allergy systems being hyper-reactive and hyper-responsive. Sometimes, and I'd say a lot of the time, the leaky gut is there, especially in a new patient, you know, who maybe has not been doing diet and functional root cause care. But absolutely, I am going to keep patients off those high triggering foods because we know they're provoking inflammation. They're not helpful in that process. And I'm going to step back, and usually in those cases, I'm going to look a little bit deeper at epigenetics or nutrigenomics.
Excellent. Now, there's a great question here about when using gut repair product, do you use this at the same time as antimicrobials and probiotics, or use them one after another for, say, 4 to 6 week period? I hear of different overarching strategies and approaches of using all in parallel or different combinations at different times and different timescales. That was a great question. So thanks.
It's a super good question. Yeah, there is no point in only doing one thing at a time or one step at a time. You're not going to get there fast enough, and you're not going to be able to really move the needle for that patient as effectively as you want to. So my main go-tos every time, anytime, and every time that I am seeing intestinal permeability, my absolute number one go-to, which I talked about in the last session with many, I'm just going to pull it back up on the screen here, and
sure.
There we go, and share my screen one more time, James. My 100% go-to when I am dealing with a permeability problem is going to be this formula from Nutridyne. Okay, excuse me. That's dynamic GI integrity. This 100% is going to be my first go-to. James, I'm going to quick grab a sip of water here.
Yeah, no problem. And then I think the next question we're talking about, which is probably very much in line with this, is about the Nutridyne Candida product as well. So that I'm sure follows very neatly after going around the GI integrity here as well. So that was one of the other questions that we've got in terms of that. If Perfect. I give you the heads up on that, that may kind of combine nicely with this one as well.
Yeah, 100%. So this is my go-to. What I love about GI integrity, it has your 3 main ingredients to repair an intestinal permeability problem. So that is your L-glutamine, it's got your DGL that's in there, and it's got your aloe extract. Now, beyond those, you see a huge array of multiple demulcents, anti-inflammatories, and anti-allergies, those that can quench and help to support some of the mast cell degradation or mast cell reactions or histamine problems that can come with food triggers. So this is 100% my go-to. You'll see there's ingredients here to support the stomach lining as much as the small intestine. So this is a esophageal issue when I've got esophageal inflammation, gastric inflammation, and small intestine permeability problems. And this is 100% the go-to. And also having that zinc carnosine in there is a nice additive for some of our patients who may be managing or dealing with challenges that involve H. pylori, or again, that gastric inflammation struggle. I want to jump ahead, and I love Nutricidin. That question popped up. It is absolutely one of my primary go-tos. Let me just see if I have a quick slide where I could grab it. Yeah, I absolutely love this formula. It is my go-to for SIBO and Candida right now. Brilliant new product in the market. It's a new in our lineup of resources for gut support. There are so many benefits to this Nutricidin. And what is great is you've got calcium EDTA, and you've got your serapeptides in here. And what do those two do that's so important is they help break up biofilms. Right. A lot of our patients who are dealing with candida or mold problems, they've got biofilm in the system. It's up in the nasopharynx, it's in the sinuses, it's in the GI tract. So this formula is designed to help break up that biofilm, to be able to get the antibiotics, antimicrobials, antifungals, and anticandidas delivered into those areas where they can reach some of those microbial challenges. So this is a fabulous formula to work with. You get the anti-inflammatory component of the ginger extract, but then you have a host of very potent antimicrobials and antifungals. So we use Nutricidin. It's a big go-to for me in my practice. This is a Rick Mayfield product. And so what I tend to do is give Nutricidin on my protocols. I give Nutricidin around breakfast and lunch. I want it to go with food. Nutricidin, you can dose 1 up to 3, breakfast and lunch. You can go up to 6 a day. And then at nighttime, I reserve before bed the window where I give my GI integrity. I give serum bovine immunoglobulins for binding bacteria in the gut. I give a spore probiotic, and I also give a Saccharomyces boulardii-based probiotic. And all of those happen before bed. So as a recap, there are 4 things I do before bed to feed and support the microbiome is GI integrity. I use GI Defend, which is that serum bovine immunoglobulin for binding LPSs. It is the number 1 that I use for binding the actual LPSs and pulling them out of the system. And then I make sure that I seed that gut appropriately and that we're giving it adequate levels of both a spore probiotic, which is going to be a lot more proactive in remodeling that gut, right? A spore probiotic is going to take a very active stance in that position, as well as candidiasis. I'm going to be using a SAC-B derived product. So the 2 probiotics that are my absolute go-tos that I mix at night, I have the patient wash down 1 ultrabiotic defense. So we get our standard probiotic strains and a good hit of Saccharomyces boulardii, which many of you know is key in that altered microbiome gut with candidiasis and with mold. Right? And then I also utilize spore probiotic. And I do that because I want those phages in there helping to move and get into and deliver some of the antibiotic messaging to really help move and clear some of the gut lining. And then I would say the last formula, which I know I talked about last month, is this GI Defend. Right, and GI Defend serum immunoglobulin binding aid. It's quite remarkable. The studies on this, I think there's 44 severe pathogens that this serum bovine immunoglobulin will attach to, grab to, and pull out of the stool. And so this, in that case I shared with you, the ulcerative colitis gentleman with his ileostomy bag, this was the key for his care. This formula, this GI Defend, along with his Nutricidin, was critical for helping him reestablish that healthy weed process. So then we could seed and feed as we head into the nighttime window. So those are my biggies. Those are my can't practice without. Like, I literally don't know if I could manage leaky gut without those tools in my toolbox anymore.
Perfect. And then there was one about L-glutamine. Do you have a problem ever with that? Or is that always goes, does that, have you ever seen any patients have issues around the L-glutamine?
No, what I basically, from the literature, and this is kind of 20 years old, anecdotally, some practitioners may find that if you're driving L-glutamine doses too high, that may lead to feeding into candida or cause people to feel worse, not better, right? And so whenever I use a formula with some L-glutamine in it, I want to be using reasonable levels. Some providers throw 10, 20 grams at people, way too much. It's not necessary. And so usually 3 grams is a standard dosing to be able to heal and work on repairing a permeability problem. I'm never giving it alone. I'm always giving it with formulas that have inulin and prebiotics and other aids. So if I'm giving that formula and it leads to some gas or bloating or distension, I ask the patient to ride it out for a week, because sometimes it's just remodeling the fiber and the microbiome. If they continue to feel bloated, then I'm going to pull them back, get them off of that prebiotic, and dig deeper and investigate for SIBO.
Good. Well, I think unless there's any more questions, I think you've done a great job of going. Just finally, any key points or highlights or takeaways that you want to give the group?
Honestly, I would say at this point, if money were not an issue with my patients when they walk in the door, and I'm 100% cash. So I would say for most patients, money is on our list, right? But across the board, I advocate that every single new patient does a KBMO for me, because there isn't anyone that has seen me that I'm not going to adjust their diet. They're coming to me for diet, nutrition guidance, and the ability to help us figure out which supplements are in their best interest. So this is one of the few tests that I recommend for everyone. And I will go back in, and if it's been 3-4 years since someone has done their food panel, I'm going to ask to have it done and revised and updated, because I feel like the clinical relevance and what patients experience when they use these results as their guide far surpasses any other labs that I have used over the last 26 years of clinical practice.
That's fantastic. And again, I think, I want to thank, on behalf of everyone, all our clients and everyone who I know who kind of comes in and re-listens to these, the experience and the kind of clinical pearls that you've handed out to us are fantastic. So very, very much appreciated. And, I think the last comment says it all. Fabulous. Want more of these, please. So, Kristi, you've knocked it out of the park again. So very much appreciated. And thank you, everyone, for listening. And again, if you are live, thank you for your questions. And if not, if you've got any more, put them down and send them to us. And again, we're happy to answer that. And we'll, if people want more, we'll be happy to do more. So thank you all again. And Kristi, a special thanks for doing that for us. Very much appreciated.
Yeah. And if anyone wants to hang out more and do cases with me, every Monday and Friday morning, I have a mentorship group, and we spend 90 minutes every Monday and every Friday. We go through cases, your cases, my cases. We write treatment plans together. We do lab interpretation. So KBMO is an anchor in all of my mentorship conversations. So if that's something that anyone is interested in at some point, that's what we do in the mentorship. And you can certainly reach out to me, and I'm more than happy to onboard you or get you engaged with that group as well. They're all health coaches, nutrition professionals, and physicians who are trained in nutritional sciences.
Wonderful. Great. Thanks everyone again. Much appreciated.
Cheers.
Thank you.